There are a whole variety of indications to do scrotal ultrasound, and you can read this at your leisure here, but we will address these as we continue in our discussion. I think it's very important to consider when you have a mass in the testis, might it be a significant lesion, particularly a malignant lesion? If you have a lesion that is solid or complex and it's palpable, it's a malignancy until proven otherwise. Even if you can't feel it, particularly if it's small, I would be quite concerned. If it is a simple appearing cyst and I don't feel it, we've already discussed that, I would tell the patient to keep their eye on it, make sure it doesn't get enlarged. If it does, come on back, but I'm really not typically worried about those. And if they're simple cysts, those small little peripheral cysts that I've already shown you of the tunica albuginea, I am not concerned about those lesions. When we have pathology involving the testis, this can involve the testis in a focal manner or a global manner. It can be echogenic, more echogenic than the background tissue. It can be isoechoic or hypoechoic. Testicular pathology that is primary generally belongs to one of four categories: neoplasm, infection, torsion, or disruption. As I've just said, this can affect the testis in a global or focal manner. Here we have 4 different patients, 4 different abnormalities, but just based on the grayscale, I don't think we can separate what's going on. Color becomes important as we add color to these 4 different cases. Once I see color in a focal area, as we see here, neoplasm will be first on my list. History also is very important. This is a focal testicular infarction. Not surprising, no flow in the area of infarction. Here's a patient with a very hyperemic testis and a focal area of absent flow due to an associated area of an abscess forming with infection, and this is a traumatic disruption of the testis where there will be no flow in the area of the hematoma. So flow and history are very important to differentiate pathology. When I do see flow, neoplasm will be first by far on my list. So let's talk a little bit about primary testicular tumors. What's interesting, if you look historically in the literature, similar perhaps to breast cancer, there's an increase of germ cell tumors, which is what we'll be talking about when we think about primary testicular tumors. A disease of fairly young people, and currently, and unlike what we would talk about perhaps 20 years ago, a very high incidence of being able to treat these men who develop primary testicular tumors. Now, underlying predisposing causes, a lot of things have been discussed in the literature, and again, you can read this list. I'm not going to go through it and read it to you. Of course, men should be the first underlying cause to develop testicular cancer, but it's also interesting to note that approximately 90% of primary testicular tumors occur in Caucasian men. 2 types of tumors are how we categorize germ cell tumors, and they're approximately half and half in the way of seminomas, pure seminoma, and non-seminomas, the latter of which are subdivided into many different types, and often you have mixed elements within the non-seminomatous group. The majority of non-seminomatous tumors have mixed elements. We can see embryonal, teratoma, choreo, and even yolk sac tumors. Well, what do they look like on ultrasound? The classic appearance, if you will, for a pure seminoma is a homogeneous mass, as we see also on Dr. Netter's very nice diagram, almost as though this patient posed for that drawing. The lobules of tumor you can see surrounded by some fibrotic bands, but basically it's a fairly homogeneous tumor. This type of tumor is reportedly increased with undescended or cryptorchid testes, and relative to the non-seminomatous group, these are less aggressive tumors that often present localized to the testis, and they are very radiosensitive. You can see the typical appearance here again in this patient, a homogeneous focal mass, but There are many, many exceptions, a much more heterogeneous mass. I'm sure you also appreciate the associated microlithiasis in this patient. The increased flow just tells me I'm dealing with a neoplasm. Now contrast this to Dr. Netter's diagram and a patient with a large non-seminomatous mass. Notice for comparison a microlithiasis riddled normal-sized testicle on the opposite side to compare to this patient with a very large mass. And I just want to make a statement here and urge all men, similar to the way we counsel women to do breast self-examination, to please be aware of your anatomy. Anybody who has a large mass, especially, if you can't explain it by infection or trauma, it's painless, please seek out help before it achieves this very large size, because neoplasm is going to be high on that list. The earlier it's treated, obviously, you have a better chance of surviving that disease. The non-seminomatous tumors, which again are more heterogeneous, sometimes have cystic elements and so forth in it, have a higher incidence of associated metastases, are less radiosensitive because this as a group are more aggressive tumors. Here we can see an example, another one, the heterogeneous appearance. This was a mixed non-seminomatous tumor. Now, just looking at this patient, it's fairly homogeneous. You might say, well, could that be a seminoma? Sure, it could be. But this turned out on pathology to be an embryonal tumor. Here we have very bright echoes, perhaps some calcification with shadowing, and that was a teratomatous tumor. Two other examples of tumors, a pure seminoma, homogeneous, and again, a relatively homogeneous, similar appearing tumor, which was a non-seminomatous tumor. Now, in this case, it wouldn't surprise you when we talk about non-seminomatous and the subcategories. Remember we said you could have embryonal tumors, you could have choriocarcinomas and mixtures. Well, those types of tumors, when you have embryonal elements, for example, just like an embryo has elevated HCG, an embryo has elevated alpha-fetoprotein associated with it, that is true with some of the non-seminomatous tumors, especially if it had embryonal elements, or if it has chorio, just like choriocarcinoma has elevated HCG, so does choriocarcinoma in the testis. What is the role of these hormones or proteins that might be elevated? These are tumor markers. We don't use them so much to make the diagnosis, although if I knew the tumor marker was elevated, I would certainly categorize what I saw, most likely as a non-seminomatous tumor. The role of tumor markers, as the word markers suggests, is following therapy to make sure that these markers go down to zero, are no longer recordable, are no longer present, because they shouldn't be if you are tumor-free. You will follow that patient, therefore, subsequently with these blood tests to see if they start to become measurable and start to increase. Then you know the patient has residual tumor present and will need therapy for that.